Hi, my name is Dr. Rajesh Shetty. I'm a lead consultant in the Department of Critical Care Medicine at Manipal Hospital, Whitefield. I'll be talking about lung ultrasound. Lung ultrasound as a concept is an interesting phenomenon because, as you know, ultrasound is very poorly conducted in the air and lung is full of air. Ideally speaking, when you do lung ultrasound, you shouldn't be seeing anything. But what happens is whenever there is a pathology in the lung, there is addition of water. And this interaction between the air and water with the ultrasound waves produces artifacts. Unfortunately for us, these artifacts are very specific to the diseases they are associated with this. And the study of these artifacts is what is the lung ultrasound. And I have to mention the name of this great intensivist from France. His name is Daniel Lichtenstein. He was the first one to identify this phenomenon more than 25 years ago. And most of the things we know about lung ultrasound is because of this great man. He has published a lot of publications, he has written several books, and he goes all over the world teaching his skills to everyone. He has come to India quite a few times as well. Now, which probes do you use? You can use any probe you have in your department. These are the three main probes which are used. The first one is called linear probe, which is a high frequency one. The other one is called curvilinear probe, which is a low frequency one. And this is called microconvex probe, which is in between frequency. Uh, the advantage of this probe is it's a high frequency, so the resolution will be very good, and it is good for examining nearest structures like pleura. This being a low frequency, it is ideal for examining deeper parts of the lung. And this has best of both. You can use it to assess pleura and also to assess the deeper structures of the lung. And because of its small footprint, it is easy to put in between the ribs, improving its visualization. How do you hold the probe? This is the usual way you'll hold, perpendicular to the skin, and the indicator should be either directed towards the head or towards the right. Which part of the lung you will examine? Basically, all lung fields you should examine as you would do with a stethoscope. Here, six fields are shown in each part of the lung. When you examine the lung, this is what you will see. This black shadow is rib, this is another rib, and this line is the pleural line. And this appearance is called bat wing appearance. The other thing you would see is called lung sliding. Can you see this pleura shimmering? This is representation of movement of parietal pleura against the visceral pleura, and this phenomena is called lung sliding. This is a normal phenomena. The other normal phenomena is what is called A lines. These are reverberation artifact of the pleura, and they will happen at a regular interval from the pleura. There is one here and there is one here, and if there is a bigger image, you will see few more at an equal distance. This again is a normal phenomena and doesn't indicate any disease. Now the third thing you need to learn is about B lines. B lines are basically the vertical lines which start from the pleura and go towards the edge of the screen. They fade as they go, and they move along the pleura during inspiration and expiration. Isolated B lines that is located more than 7 millimeters from adjacent B-man is a normal finding. B lines are also normal in lower dependent parts of areas in up to 28% of normal patients. B lines are said to be abnormal when you see three B lines or more in a single scan using a microconvex probe, or at least 6 B lines using a linear probe. Important thing about B lines is it's very sensitive. You will be able to see B lines much before the abnormalities are seen on chest X-ray, and also the number of B lines is directly related to the severity of the disease. For example, in cardiogenic pulmonary edema, the more severe the pulmonary edema, the more B lines you will see. And it is very sensitive to the change as well. For example, if the pulmonary edema is treated with either a dilusis or dialysis, if pulmonary edema clears, the B lines will clear as well. So in this way, it is very useful to evaluate the response to therapy. This is some example. This is a mild pulmonary edema where very few B lines are seen. Here, this is more severe disease where more B lines seen, and this is extensive B lines, as indicating much severe lung disease. What are the conditions which can be diagnosed by lung ultrasound? These are the four main ones: pneumothorax, pleural effusion, pneumonia, and alveolar interstitial syndrome, which includes ARDS and pulmonary edema. First, pneumothorax. Pneumothorax is defined as a diagnosis of exclusion with respect to lung ultrasound. When there is a pneumothorax, the parietal and visual pleura will be further apart, so you will not see B lines. If you are seeing B lines and if you are seeing pleural slide, it practically rules out pneumothorax. You can confidently say that this patient doesn't have a pneumothorax. This is the pleural slide which is shown. Again, if there is a pleural slide, it means there is no pneumothorax. Absence of pleural slide and absence of B lines might indicate that a patient has a pneumothorax. The other sign which is seen is called seashore sign. Here, basically, M mode ultrasound is used, and when you pass the ultrasound wave and do a M mode, this is what you will see in a normal situation. This is called seashore sign. This looks like sea and this looks like shore. Just to example, the pleura and the lung will look like shore, and the intercostal space and skin and subcutaneous tissue will look like sea. When you have a pneumothorax, that appearance is abolished, and what you will see what is called a barcode or stratosphere sign, where you will only see sea. There is no shore. This is just to compare. This is seashore sign, and this is barcode or stratosphere sign. The other only positive point with respect to lung ultrasound in pneumothorax is what is called a lung point. Lung point basically indicates a point where visual pleura has separated from the parietal pleura, and therefore it defines the point where the pneumothorax begins. If you can see this, you can say with 100% specificity that there is a pneumothorax. This is an example of lung point. Can you see here? The pleural slide is seen here, and there is no pleural slide seen on the other side. The junction between those two is called lung point. Where is the best place to look for pneumothorax? Pneumothorax is a non-dependent entity. So in a patient who is slightly sitting head up in a supine position, the most apical and medial position of the chest is the best place to look for pneumothorax. For example, in the second intercostal space, medially, lateral to the sternum. Pleural effusion is another example where ultrasound can be used, and you can say that probably ultrasound is the most sensitive modality to look for pleural effusion compared to chest X-ray, and maybe comparable to CT scan as well. What you will see is an anechoic structure where there is a fluid. For example, this is the pleural effusion. The next one is pneumonia. Pneumonia will look like a hypoechoic structure. Usually the boundary between the pneumonia and the normal lung will look like a irregular shaded boundary, which is called a shaded sign. And if the pneumonia is very severe, the lung will look like liver, called hepatization or liver-like, with irregular boundaries, indicating the severe pneumonia. Here, the hypoechoic structure is seen with whitish punctiform things. This is what is pneumothorax. And there is one interesting thing about these hyperechoic punctiform images. As you can see, these hyperechoic signs, they become more intense and less intense with inspiration and expiration. This is called dynamic air bronchogram. And if you can see this, this is 100% specific for consolidation or pneumonia. If it is not there, it may be consolidation, or it can be maybe just atelectasis of the lung as well. Now, what is the evidence we have? This is a paper which was produced in 2012 called International Evidence-Based Recommendation for Point-of-Care Lung Ultrasound. It was supposed to be produced every 4 years, but unfortunately after 2012, no further papers have been published by this group. At that time, they looked at 320 references and they made 73 recommendations. And they gave a strong level A recommendation where they felt that further research is very unlikely to change our confidence in the estimate of effect or accuracy. And strong level A recommendation was given for these four pathologies: alveolar interstitial syndrome, pneumothorax, pleural effusion, and pneumonia. Now, just briefly about COVID pneumonia. These are the changes you will see with lung ultrasound in a patient with COVID. Thickened irregular pleural line, sub-pleural shedding, sub-pleural consolidation, increased B lines, patchy distribution, consolidation with air bronchogram, excuse me, pneumothorax, pneumomediastinum, and I put it pleural effusion here. Even though, according to evidence, about 20 to 30% of the patients, the COVID pneumonia might have pleural effusion. In our experience, especially in the second wave, not even a single patient had pleuration because of COVID pneumonia. If they have a pleural effusion, it is mainly because of circadian fluid overload or some other pathology. This is how a thickened pleura will look, this compared to a normal one. Subpleural setting is seen here. The COVID pneumonia is merely a peripheral lung disease compared to the inside of the lung. The changes are very next to the pleura, which is called subpleural shedding. The other thing you might see is what is called subpleural consolidation. This looks like a bite of lung has been taken off. This part is called subpleural consolidation, again indicating a peripheral disease, and the distribution will be patchy of this. Again, another characteristic feature of COVID pneumonia. Here, a combination of thickened pleura with the subpleural consolidation is seen, another feature of COVID pneumonia. Obviously, as the disease progresses, you might see increased B lines. You might see a subpleural consolidation with increased B lines. And another thing you would see while assessing COVID pneumonia patients is their full fluid status. So the visualization IVC, which is full, might indicate that negative fluid balance may be useful for these patients. Some of the COVID pneumonia patients might get other complications like pneumothorax. Here, one example of that with the absent pleural slide and the barcode sign. They may also get consolidation, which usually indicates secondary pneumonia. As I say, because of other pathologies like a circadian fluid overload, they may have a pleural effusion as well. These are the other things which can be diagnosed with ultrasonography or can be used for it. One is to assess the reduced chest excursion. It can be used to assess for weaning failure, look for diaphragmatic thickness, also for recruitment while doing physiotherapy and tracheostomy. Just briefly, this is looking at the diaphragmatic movement. It should be more than 1 centimeter. This is diaphragmatic thickness. Thickness, you should be more than 1 millimeter. It will be reduced in those patients who have diaphragmatic thinning because of prolonged ventilation. Here, recruitment, as you can see, the whitish punctiform lesions. With physiotherapy, if there is a recruitment, they will clear, indicating successful physiotherapy and recruitment. Ultrasound can be used for tracheostomy as well, where you would be able to identify cricoid and the tracheal rings, and also identify the blood vessels which can be avoided. So, in summary, ultrasound is a useful tool for assessment of critically ill patients. The main uses are for diagnosis of pneumonia, pneumothorax, pleural effusion, alveolar interstitial syndrome, and nowadays in COVID pneumonia. It can be used for other uses as well, and more uses are coming up as we are becoming more comfortable in the use of lung ultrasound. They include diaphragmatic excursion, diaphragm thickness, weaning, recruitment, and tracheostomy. Thank you.